Hello everyone, this is Dr. Frances Munroe from the George Washington University School of Nursing, and today we're going to talk about adrenal and pituitary disorders. First, I'd like you to take a look at this slide that shows a nice review of the physiology of the adrenal glands and the different hormones that are produced, the interaction between the hypothalamus, the anterior pituitary gland, and the adrenal gland with the secretion of the hormones that are critical. This resource came from the Adrenal Cortex Development, Anatomy, and Physiology from the endotext.org website. Let's look specifically at adrenal disorders first. They're characterized by either adrenal hyperfunction or adrenal hypofunction. Some of the more common diseases that we see when the adrenal glands are overproducing would include diseases such as Cushing syndrome with the excess in glucocorticoids, hyperaldosteronism with the excess in mineralocorticoids, congenital adrenal hyperplasia with excessive androgens, and pheochromocytoma with excessive catecholamine production. When we look at adrenal hypofunction, primary adrenal insufficiency comes to mind. That would be a low cortisol or aldosterone production with an elevated ACTH. And the central adrenal insufficiency shows the low ACTH with the low cortisol levels. Let's talk a little bit about adrenal insufficiency and Addisonian crisis. First, we'd like to look at the prevalence of primary adrenal insufficiency, and cases have doubled over the past several decades, from 40 to 70 cases per million in the 1960s to now 93 to 144 cases per million population by the end of the last century and in recent years. The current estimates show that approximately 5 to 6 new cases per million population per year. Primary adrenal insufficiency affects more women than men, and the clinical manifestations of the disease can present at any age, although usually occurring between ages 30 and 50 years old. Secondary adrenal insufficiency occurs more frequently, and its estimated prevalence is up to 280 people per million and is more common again in women than men, and this usually affects more elderly. Adrenal insufficiency can be a life-threatening disorder. It is characterized by a lack of production of the action of glucocorticoids and or mineralocorticoids and adrenal androgens. So let's take a look at the patient who presents. Some of the symptoms that you might see would be severe fatigue, weakness, GI distress, intense cravings for salt, unintentional weight loss, fever, dehydration, nausea, vomiting. On physical exam, you would notice again the weight loss, hypotension, vitiligo, or hyperpigmentation of the skin. Some of the initial lab workup might show results such as hyponatremia, hyperkalemia, hypoglycemia, eosinophilia, and lymphocytosis. Certainly your workup would want to include testing for other autoimmune disorders such as diabetes, and probably a CAT scan to look for any adrenal calcifications. If we look specifically at primary insufficiency of the adrenal glands, Addison's is the most common. It is an autoimmune adrenalitis, is making up 80% of the primary insufficiency. Other causes would be infections such as tuberculosis, HIV, cytomegalovirus. Also, this condition is seen with metastatic cancer. Some rare causes might be adrenal hemorrhage or infarct, other infiltrative diseases, certain medications, and even the trauma from surgery. When we look at secondary or tertiary adrenal insufficiency, the pituitary gland can be implicated with things such as tumors, after effects of radiation, infiltrative diseases, cerebral infarcts, or trauma. The hypothalamic area is responsible for the tertiary causes of adrenal insufficiency. And again, glucocorticoid therapy, anything prolonged, even 20 milligrams of prednisone over a 5-year period, or greater than 5 milligrams of prednisone daily for a month can cause adrenal insufficiency, as can tumors or radiation to that area. The diagnostic workup for adrenal insufficiency includes some baseline labs. You would want to get a basal morning serum cortisol level, ACTH level, aldosterone level, all very important. The gold standard is the ACTH stimulation test, and this little chart shows the interpretation. Usually it's a stimulated cortisol of greater than 18 to 20 micrograms per DL is considered a normal response when given the standard 250 micrograms ACTH test. A high ACTH would indicate the primary adrenal insufficiency, and a low or normal ACTH would show secondary adrenal insufficiency. Basically, when this test is performed, the protocol calls for the baseline cortisol and aldosterone blood work to be drawn, and then ACTH is either given IV or IM, and remeasurements of the cortisol and aldosterone levels are taken at 30 and 60-minute intervals with response noted. As I mentioned earlier, acute adrenal crisis is a life-threatening condition, and treatment needs to be urgently initiated. Patients need to be hospitalized. Hydrocortisone needs to be given 50 to 100 milligrams IV every 8 hours. IV fluids are given to maintain adequate blood pressure control, and of course a thorough workup to rule out the precipitating factors such as trauma, infection, dehydration, stress. You'd want to taper the glucocorticoids as quickly as possible and return to the maintenance dosage, and obviously discontinue the glucocorticoids if there is a normal ACTH stimulation test found. Patients with chronic treatment of adrenal insufficiency should be treated with either hydrocortisone, the natural glucocorticoid, or cortisone acetate if hydrocortisone is not available. The daily dose is usually 10 to 12 milligrams per meter square of body surface area, and can be broken into 2 to 3 divided doses, with 1/2 to 2/3 of the total daily dose in the morning. You might notice small reductions in bone mineral density due to higher than recommended doses, as well as an impaired quality of life. It is very important to stress patient education, and that the patient wears medic alert in case of any type of Addisonian crisis, which provides the information on the diagnosis, the medications, the daily doses, and who the endocrinologist is that is caring for the patient. They should always have supplies of dexamethasone sodium phosphate and how to administer in case of an emergency. So patient and family education is very critical. As mentioned earlier, as quickly as the patient can be tapered down, the lowest dose of steroids should be given to control the symptoms and prevent further complications from high doses of steroids, which would include Cushing's disease, early osteoporosis, or diabetes. Now we're going to move on to another section and talk a little bit about pituitary disorders. Once again, let's start by reviewing some of the normal physiology. If we look at the anterior portion of the pituitary gland, we see that this is where cellular masses can be found, pituitary adenomas. These can occur up to 80% of the pituitary gland is in the anterior portion, and therefore can affect things such as hyperfunction or hypofunction, and can lead to hypopituitarism. If we look at the posterior portion of the pituitary gland, this is where you may find overproduction of AVP, which can lead to the syndrome of inappropriate antidiuretic hormone secretion, or you can see underproduction of AVP, which can cause diabetes insipidus, which may be either central or nephrogenic. Again, if we look at the specific hormones on each side of the pituitary gland, in the anterior portion, we have the hypothalamic releasing hormones that control the anterior pituitary hormones and the target organs. And in the posterior portion of the pituitary gland, the hypothalamus, supraoptic, and paraventricular, leading to the posterior pituitary and producing the AVP and oxytocin, as mentioned earlier. So if we look at the etiology of pituitary adenomas and some of the epidemiology, they are the third most common brain tumor. They account for almost 10 to 15% of all intracranial tumors. MRI is the gold standard for detecting a pituitary tumor. It is allowing for the optic chiasm, the cavernous sinuses, the pituitary, the normal gland, and any tumors, and the stalk. And in addition, you can see aneurysms of the carotid. So the MRI allows for the most accurate measurement of the size of the pituitary and any other tumors that may be associated with it. However, if MRI is not available, CT scan is also helpful, but the resolution is not as good. There is no recommendation for any routine skull x-rays for determining any pituitary adenomas. Specifically on MRI studies, we'll also see up to 14% of adenomas found incidentally, and on autopsy, 12 to 22% of pituitary adenomas are an incidental finding. These tumors are also classified according to size. Microadenomas are usually less than 10 millimeters, and macroadenomas are greater than 10 millimeters. It is very important, obviously, to take a very complete history and perform a complete physical exam on your patient. Questions regarding any endocrine hypo or hyperfunctioning would be very important as you're thinking of either the anterior and posterior areas of the pituitary gland and how they function. If we look at hypofunction, think of underactive thyroid or hypothyroidism, hypogonadism, adrenal insufficiency, growth hormone deficiency, and obviously with hyperfunction, you may see hyperthyroidism, excess of prolactin, Cushing's syndrome, or growth hormone excess. For both conditions, you may find neurological complaints, including increase in headaches or visual disturbances, and so it is very critical to check for visual field testing during your physical exam. The lab workup for pituitary disease usually starts with your hormone workup, including thyroid testing, TSH, and free T4. Sometimes you may need the total T4 and T3. If the TSH is normal but you've got the low free T4, that usually means hypothyroidism. But if the TSH is normal to high and the free T4 is high, then you can be thinking about a TSH secreting tumor. Other reproductive organs affected would be looking at prolactin levels. A mild elevation, you would consider different diagnoses. Greater than 100 is likely a prolactinoma. And this is very critical to assess and to rule out prior to any type of surgery. FSH, LH should be looked at, and testosterone levels in men, estradiol levels in women, especially if you're seeing things such as amenorrhea or infertility. Growth hormone is important to measure. If the IGF-1 is low and the growth hormone is normal to low, then you may have the growth hormone deficiency. If the IGF-1 is high, growth hormone is normal to high, then you're going to have a diagnosis of acromegaly. As we mentioned in some previous slides, it's important to look at the adrenal glands and measure the ACTH and cortisol levels. If you've got low levels, then you're looking at adrenal insufficiency, high levels at Cushing's disease, and you would then need the dexamethasone suppression testing. You may also need extra testing if the growth hormone and ACTH excess is suspected. Here are some brief facts about prolactinomas and the epidemiology and prevalence. As you can see from autopsy studies, it's almost 3 to 5%. The incidence worldwide is 1 to 2 cases per million per year. And prolactinomas account for almost 30 to 40% of all pituitary tumors and 5% of all intracranial tumors. It is very common, actually more common in women than men, 3 times greater. And premenopausal women will have an earlier onset of symptoms and usually have more microadenomas versus the postmenopausal women and men who have later onset with more macroadenomas, which, as you remember, are greater than 10 millimeter in size. What are some of the treatment options available for prolactinomas? Usually the cornerstone is medical therapy to start with using the DA agonists. Cabergoline is preferred over bromocriptine, usually resulting in a reduction in tumor size, a resolution of the visual field defects, resolution of amenorrhea, infertility, and a resolution of galactorrhea with a return to normal for the prolactin levels that were elevated. Cabergoline has a very long biological half-life and fortunately only needs to be administered either once or twice per week at a dose of 0.5 milligrams per dose. It can be gradually increased up to 1 milligram to a daily dose if needed. It is usually better tolerated than the bromocriptine, so patients are usually more compliant. So cabergoline is considered the first choice drug for treatment, except for patients who want to get pregnant in the short term. One of the challenges with the medications is that they need to continue for a long period of time, which is very difficult for patients, especially since they are usually asymptomatic. Transsphenoidal resection surgery is considered second-line therapy for most cases, especially if patients are resistant or intolerant to the cabergoline or bromocriptine. However, surgery does not always help with the very large tumors and does not help to reduce the serum prolactin levels. Radiation therapy is considered third-line therapy for residual tumors after surgery or for very aggressive or resistant type of tumors. Some of the specific treatments for the management of hypopituitarism would be the specific hormones involved, including replacement of levothyroxine for thyroid hormone. The TSH cannot guide the treatment in this case. The free T4 you would want to maintain in the upper normal range. For adrenal symptoms, hydrocortisone or prednisone low dose, mineral corticoid therapy is usually not needed. Men may require testosterone replacement, and women may need either hormone replacement therapy if they are postmenopausal or oral contraceptive therapy if they are premenopausal. For growth hormone issues, patients can be treated with RH growth hormone. For prolactin problems, there are no replacements available or required. If there are problems in the posterior pituitary gland, DDAVP can be given. And of course, it is very critical that the patient is wearing a medical alert bracelet or tags, and always be consulting with their endocrinologist. All of these conditions require referral to endocrinology for those of us working in primary care. I'd like to thank you for your time today. I have listed several references that I use throughout the presentation for further reading. Thank you.